Very good afternoon from Singapore and good morning and maybe evening from wherever you are. Welcome to the ISCP 2021. My name is Doreen and I'm standing in for the original chairperson, who is Professor Juan Carlos, and he couldn't be with us today. So we are going to start our session on the inflammation as a target for ischemic heart disease, why and how. And let me introduce to you our faculty for today. The speakers for today will be Professor Wolfgang Koenig, as well as Professor Alberto Lorenzatti, and we have a panel of distinguished speakers today as well. The content of this webinar is copyrighted by the ISCP and should not be distributed without the prior permission of the ISCP. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of ISCP. The session will be live streamed via Wonder and ISCP and APSC Facebook, as well as YouTube pages. The European Board for Accreditation in Cardiology, or EBAC, grants the CME points for attendees who attend the full session, and you will receive your certificate of attendance upon completing a survey that will be sent to you via email after this webinar. So if you have questions, please post your questions in the live Q&A box in the right-hand side of your screen. And we will be getting to the questions at the end of the session after the two speakers have delivered their talk. So without further ado, let me introduce to you our first speaker for the day, Prof. Wolfgang Koenig, and he's the Professor of Medicine and Cardiology at the German Heart Center in Munich, Germany. He's going to be addressing us on the topic of inflammation as a target for ischemic heart disease, why and how. Professor Koenig, please.
Dear colleagues, it's my pleasure to discuss with you the role of inflammation as a target for ischemic heart disease, why and how. My name is Wolfgang Koenig. I'm a professor of medicine and a consultant cardiologist at the German Heart Center in Munich, and I have a strong, long-standing interest in inflammation and atherosclerosis, both from an epidemiological point of view, but also as a clinical trialist. Now, here are my disclosures. From a historical point of view, Rudolf Virchow was the first to mention the possibility that inflammation in the vessel wall may contribute to atherosclerosis, in particular to atheromatous degeneration, and he called that endarteritis. Now, this was almost 50 years before Nikolai Anichkov showed that cholesterol alone caused the atheromatous changes in the vascular wall and described the specific heart macrophages, the so-called Anichkov cells, and developed the first experimental atherosclerosis model, the cholesterol-fed rabbit. Now, it took another 70 years until vascular biology started to unravel the molecular mechanisms in more detail of atherosclerosis and its progression. And nowadays we know that at all stages of the atherosclerotic process, these inflammatory processes do play a significant role. Now, this shows you what happens at the beginning of atherosclerosis. And we all know, and there's a broad consensus, that it starts with endothelial dysfunction. And endothelial dysfunction means that it can be penetrated by cells and various lipoproteins from the lumen to the intimal space. And you see on the left side, for example, LDL, that is then minimally modified or oxidized in the subintimal space, taken up by macrophages, and then the macrophages turn into foam cells, the crucial cell of the atherosclerotic plaque. Now, the macrophages depicted here are very productive in terms of pro-inflammatory cytokines, for example, IL-6 and TNF-alpha. In addition, chemokines do play a significant role, for example, MCP1, because it facilitates the penetrance of monocytes from the lumen of the vessel wall into the subintimal space, where they then are being transferred to macrophages as shown here. Now, besides the monocyte macrophages that I just mentioned, other cell types do play a role, like mast cells. Most recently, neutrophils have been recognized to play a very important role in atherosclerosis, and also platelets secrete various pro-inflammatory mediators. In addition to those cells relevant to the innate immune system, There are also other cells reflecting the adaptive immune system, like B cells, T regulatory cells, etc., that are that play a role in the atherosclerotic process. In more detail, you see in the upper panel two macrophages. On the right side is the pro-inflammatory phagocytic M1 macrophage that produces TNF-alpha, IL-1, and also various chemokines. And below, you see T lymphocytes, for example, and the T helper 1 cells are secreting interferon gamma, which is a crucial glycoprotein that is relevant for the collagen synthesis, and it breaks down the collagen in the plaque cap in the atherosclerotic plaque. Now, what's happening in the vascular wall is mirrored by systemic changes, and you do see here a timeline of atherosclerosis, and at the bottom there are various cytokines, chemokines, and other markers more specifically related to plaque destabilization. And there is an abundance of studies, long-term prospective epidemiological studies, very well controlled, that do show that elevated levels of these markers that are shown here in the vast majority of instances are independently related to various cardiovascular outcomes. So this underlines that atherosclerosis is a systemic disease. Now, the first clinical trial that has looked into the importance of a specific marker of inflammation, HSCRP, was the Physicians' Health Study. It was published by Paul Ritter in 1997, and it was a trial that tested the hypothesis whether or not aspirin may be able to reduce future myocardial infarction in otherwise healthy physicians. And what Paul Ritter could show is that there was across quartiles of C-reactive protein a strong increase in risk, which was attenuated and almost non-significant in the intervention group. A few years later, Tillman Cyrus, in a mouse model, LDL receptor negative mouse model, showed that low-dose aspirin, a dose given to similar given to humans, was associated with reduction in various pro-inflammatory markers, as well as reductions in aortic lesions and macrophages, and an increase in smooth muscle cells and collagen. Now, a few years later, after quite a number of epidemiological studies have been carried out, the first meta-analysis was presented by the Emerging Risk Factor Collaboration Group, and you see the association between geometric mean levels of C-reactive protein and coronary artery disease in the upper panel, and with ischemic stroke in the lower panel. And I think you can appreciate that there's a fairly strong and consistent positive association for both of these endpoints, which is somehow attenuated when you introduce clinical variables, and further attenuated if you introduce other markers of inflammation. Now, bottom line from these data is that the predictive value of C-reactive protein is as strong as the one shown for traditional risk factors like systolic blood pressure and non-HDL. Now, these data are based on very large numbers of subjects who did not go on for an event and subjects who suffered from a fatal and non-fatal outcome. In addition, we have learned from chronic inflammatory diseases that the majority of them are associated with multiple cardiovascular and diabetic outcomes, as seen here: autoimmune disorders, vasculitis, psoriasis, for example. You clearly see that there's an increased risk to suffer from myocardial infarction and other cardiovascular endpoints for patients with these diseases. In more detail, the authors could show that there is even a dose-response relationship. If you look at the bottom here, it shows the tertiles of C-reactive protein, and the higher the C-reactive protein, the higher is your risk for a multiple outcome of a coronary disease, or for stroke, or diabetes mellitus in these patients with chronic inflammatory conditions. Now, from a clinical standpoint, it was the landmark study by Giovanni Luzzo et al. From Rome, who has published a seminal paper in only 34 patients with Brown class 3B, and showed that elevated levels of C-reactive protein and SAA on admission were associated with adverse clinical outcome. Now, this was the basis for a continuous increase in this phenomenon, and it was first replicated by Fritz Haverkade, who published the ECAT study a few years later, a larger sample where they also could show that C-reactive protein is associated with coronary disease in stable and unstable angina patients. Now, for a long time, we have exclusively focused in our pathophysiological concept on the so-called vulnerable plaque, which means a plaque that is showing inflammatory activity, and at some point in time, because of this inflammation and also external and external stresses, ruptures, and then the content of the plaque gets into contact with the bloodstream, and you will see a thrombus on top of that, which then leads to an ischemia in the downstream vascular bed. Now, today we have to realize that not all of these plaque ruptures are associated with inflammation. For example, the famed study by Arturo Masuri some time ago has shown that about 40% of patients with ACS are not showing signs of systemic inflammation. And we also appreciate that there is an increasing number of patients with a different pathophysiology, namely they suffer from plaque erosion, and on top of this erosion, then you see the formation of a thrombus. So the situation is not as easy, as simple as we thought in the beginning. Now, in contemporary populations, in patients with coronary artery disease, there is still an increased inflammatory residual risk. As you can see here from the stability study, it was a study with an LPPLA2 inhibitor, and you can see across various endpoints, cardiovascular endpoint, but also not cardiovascular endpoints. If you look into quartiles of C-reactive proteins, you can clearly see with increased C-reactive protein and increased risk to suffer one of these endpoints that are shown on the left side. Now, the similar observation has been done with IL-6, and IL-6 may be even more important because IL-6 has been shown to be causally involved in the atherosclerotic process. Again, across quartiles of interleukin-6, you see a significant increase in the risk for these various outcomes, shown on the left side. Now, what about today if you have controlled your LDL? Is inflammation still relevant? And this is data from a large PCI registry from New York. And what you see here is that patients who do have high CRP before elective PCI and have high CRP after have a twofold increased risk for major cardiac and cerebrovascular events compared to those who have a low CRP before intervention and after intervention. Also, in the context of aggressive lipid lowering, as here with evolocumab, a PCSK9 inhibitor, you see that even in when you have reached a very low LDL level, namely 20 milligrams per deciliter, you easily can see that C-reactive protein is able to modify risk. So clearly, there is a residual inflammatory risk. Now, is it frequent? Yes, it is. If you look at these 3 clinical trials, all of them have been done with lipid lowering trials. You see in the black part of the pie chart, about 1/3 of those do have a residual inflammatory risk, which was defined with an CRP above 2 and an LDL-C less than 70 milligrams per deciliter. Now, in the early phase of our attempts to treat patients with atherosclerosis with an anti-inflammatory therapy, we were not really successful. And you can see here, despite positive preclinical studies and also positive pilot clinical studies, a failure in the outcome trial with regard to P-selectin, with regard to losmapimod, which was a P38 MAP kinase inhibitor and antioxidant, several phospholipases in a solid and the stability trial, and more recently methotrexate. They were all negative in the end. And only extensive research over the last 10 years and the positive results from Cantos and colchicine, about which you will hear more in a minute, are suggesting that there is one central pro-inflammatory pathway that may play an important role, and this is the inflammasome IL-1 beta IL-6 pathway. Now, what is the NLRP3 inflammasome? It's a cytosolic polyprotein platform that mediates pro-inflammatory stimuli, like, for example, mediated through cholesterol crystals, neutrophil extracellular traps, atheroprone flow, and hypoxia in the atherosclerotic plaque. This leads to increased secretion of pro-IL beta. The caspase-1 system then transfers it into active IL-1 beta, and if you then go further down the road, there's increased IL-6, which then stimulates the acute phase reaction in the liver with consecutive elevated levels of C-reactive protein, PI1 fibrinogen, and other acute phase reactants. And you can also see on this slide that there are various possibilities to intervene with this pathway, and you will hear more about that in the next talk. Now, in summary then, pro-inflammatory processes in the vascular wall are present during all stages of atherogenesis. Elevated concentrations of various cytokines, of various sensitive markers of inflammation are associated with cardiovascular, but also non-cardiovascular outcomes. Various clinical syndromes associated with subclinical inflammation show an increased risk for adverse cardiovascular outcomes. And finally, inflammation seems to play a role even in the presence of very low LDL, really suggesting that there is a residual inflammatory risk. With this, I would like to conclude, and thank you very much for your attention.
Many thanks, Professor Koenig. This is such fascinating information. You will be thinking about inflammation, but you wouldn't be thinking about inflammation and atherosclerosis. And this is such an important pathway, thinking about what else we could be targeting besides the things that we already know now in terms of LDL lowering as well as aspirin. So it was good to hear from Professor Koenig. Let me introduce the next speaker, and the next speaker is Dr. Alberto Lorenzatti, and he's co-director of the DAMIC Medical Institute in Argentina. He'll be addressing us on anti-inflammatory treatments for IHD, the results of recent trials, and what next. I suppose Dr. Lorenzatti will be addressing the issues that were shared by Professor Koenig earlier on. Dr. Lorenzatti, please.
Hello. It's a pleasure to be here in the annual meeting of ISCP this year based in Singapore. The topic that I will address is anti-inflammatory treatment for ischemic heart disease and the results of recent clinical trial and next steps. This is my disclosure information. The involvement of inflammation in the pathogenesis of atherosclerosis has been suspected since the 19th century. The idea as the lipid-dependent disease has dominated the field of atherosclerosis during many, many years. Just only in recent times, inflammation has begun to be recognized as an important factor in the development of atherosclerosis cardiovascular disease, and its role is nowadays quite well known. The problem is that inflammation involves multiple regulatory and compensatory mechanisms and is a very difficult therapeutic target. Lipid dysregulation promotes the atherogenic process, this is very well known, but also immune inflammatory responses. The LDL retention, the LDL modification in the subendothelial space, the transmigration of monocytes transformed in macrophages, the formation of foam cells, but pay attention to the cholesterol crystals that are very abundant in the lesions. Cholesterol crystal can trigger or can stimulate the activation of the inflammasome, that is an intracellular protein complex, able to promote the activation of interleukin-1 beta. And other inflammatory biomarkers downstream, like interleukin-6, and finally C-reactive protein. The first study that pointed out the relationship between inflammation and atherosclerosis in a very important way was the Jupiter study. You remember rosuvastatin 20 milligrams against placebo in patient in primary prevention without coronary heart disease. The results were very impressive, more than 50% of relative risk reduction. But in patients who on treatment achieves the lower levels of LDL and the lower levels of C-reactive protein, they showed an impressive near 80% relative risk reduction of the primary endpoint. But the problem with Jupiter and other similar studies with the statins was how to separate, how to split if these effects were due to LDL reduction, were to biomarker of inflammation or inflammation reduction, or both. For this reason, the CANTOS study was designed with the aim of purely intervene in the inflammatory pathway without affecting lipid levels. The drug that was used in CANTOS was canakinumab, a fully humanized antibody against interleukin-1 beta. The study included more than 10,000 patients with stable coronary artery disease, divided in 4 arms, placebo, and 3 different arms with 3 different doses of canakinumab. The primary endpoint was a triple MACE, and the key secondary endpoint was the triple MACE plus unstable angina required revascularization. Regarding the baseline characteristics, the vast majority of patients were in lipid lowering, more than 93%. The LDL average basal levels were about 82 milligrams per deciliter, but the basal levels of C-reactive protein was 4.1 milligrams per liter. Canakinumab produces a significant reduction in the biomarker of inflammation C-reactive protein without a significant modification in LDL, HDL, or triglycerides. The results were impressive, and the first comproval of the hypothesis of the atherosclerosis, the reduction of 17% in the primary relative risk reduction, I mean, in the primary endpoint, and a 17% relative risk reduction in the MACE plus. In some selected endpoints, like myocardial infarction, urgent revascularization, or any coronary revascularization, there were very interesting results, more than 30% in general for this selected endpoints in terms of relative risk reduction. In a very interesting way, patients who achieved the lowest levels of C-reactive protein showed more better results, 25% relative risk reduction regarding the primary endpoint. And in terms of all-cause mortality or cardiovascular mortality, that in the entire cohort of CANTOS, there were no modification in patients who achieved after the first dose of canakinumab the lower levels of C-reactive protein. In our words, in other words, showing a robust inhibition of the inflammatory response, there were 31% reduction in both cardiovascular and all-cause mortality. Similarly, in patients who reduced with canakinumab in a very important way, interleukin-6, also there were 36% relative risk reduction of the primary endpoint. In CANTOS, there were also non-cardiovascular clinical benefits, for example, reduction in lung cancer and in cancer mortality. But the problem was that there was an increase in fatal infection in patients treated with canakinumab, small in amount, but statistically significant. Probably for this reason, canakinumab will not be used in clinical practice in secondary prevention, and the regulatory authority denied the authorization for this purpose. In conclusion, CANTOS demonstrated that targeting interleukin-1 beta with canakinumab reduces cardiovascular events, provided the first proof of concept regarding the inflammation as a cause of atherothrombotic outcome, and the magnitude of C-reactive protein reduction showed a simple way to identify individuals more likely to achieve more cardiovascular benefit. Regarding methotrexate, it was tested in the CERT trial using low dose of methotrexate in patients with stable coronary heart disease, type 2 diabetes, or metabolic syndrome. The CERT trial was stopped and its results were absolutely neutral. Regarding colchicine, is an alkaloid, very useful in gout, pericarditis, etc. And also, colchicine inhibits multiple inflammatory pathways, including the blocking of cholesterol crystal-dependent inflammation activation. For this way, reducing interleukin-1 beta and interleukin-18 activation. The first important trial showing benefit was COLCOT in 4,700 patients within 30 days post-MI. The patient received colchicine 0.5 milligrams per day against placebo for an average period of 22 months. The COLCOT was a positive trial showing 23% reduction in the primary, statistically significant in the primary endpoint. There were also two more studies, low-dose it was a small study, and recently low-dose 2 study in patients with stable coronary artery disease, including 5,500 patients and followed by about 28 months, showed also a very important risk reduction, 31% risk reduction for the primary endpoint. But not all are good news in terms of targeting inflammatory modulation. In the slide, you can see a list of many trials investigating different approach for modulation of inflammation without positive result, with succinylbucol, varispladib, darapladib, inclacumab, losapimod, etc. Only colchicine and canakinumab have shown good result in terms of reduction of inflammation and reduction of cardiovascular events. Probably this pathway, the pathway of interleukin-1 beta, interleukin-6, is up to now the only pathway, inflammatory pathway that its intervention is showing positive results. There are many different meta-analyses showing the importance of the utilization of colchicine in the prevention of cardiovascular disease. This is a very recent meta-analysis taking the diabetic patient of many clinical trials, LOCO-2, COLCOT, LOCO-2, COPS and CANTOS, and the authors are showing a 20% risk reduction of cardiovascular events in patients with diabetes included in the clinical trials that we are talking about. But not all are good news. There are some meta-analyses with colchicine showing no good results. For example, this is a very recent meta-analysis, including 6 research randomized clinical trial and more than 6,000 patients, that this meta-analysis is showing that in post-acute myocardial infarction, colchicine did not reduce cardiovascular all-cause mortality, cardiovascular mortality, recurrent myocardial infarction, and other cardiovascular outcome. But the good news is that colchicine in this meta-analysis did not increase drug-related adverse events. What about new direction? Several anti-cytokines agents are under active study now. Anakinra, a monoclonal antibody against interleukin-1 receptor, attenuates the release of inflammatory markers in post-MI patients. Tocilizumab is a monoclonal antibody targeting interleukin-6 receptor and attenuate the release of inflammatory markers, troponin, every 3 days, over 3 days following myocardial infarction. The direct inhibition of inflammasome in animal models reduced infarct size and preserved cardiac function. In other words, the intervention of inflammasome is other interesting way to try to reduce cardiovascular events. And final, siltivekimab, a fully human monoclonal antibody directed against interleukin-6 ligand, effectively reduced biomarkers of inflammation and thrombosis in patients with very high cardiovascular risk. Finally, there is a huge evidence of the different pro-inflammatory pathways are involved in atherosclerosis process. CANTOS is specifically designed to demonstrate that decreasing inflammation is correlated with reducing clinical event. It was the first proof of concept. The administration in this trial of canakinumab showed clear benefit. Recently, the concept was endorsed by the use of colchicine in COLCOT, LOCO-2 study, but further confirmation and carefully evaluation of the balance between benefits and adverse events is still needed before our guidelines can endorse the use of colchicine in secondary prevention of cardiovascular disease. The conclusion is there is necessary more research in this field. Thank you so much for your attention.
Thank you, Dr. Lorenzatti, and welcome all our panelists to our panel discussion. I thought the concepts that were shared were very fascinating. Some of the new drug names I couldn't even pronounce, Zitavekimab, for example, was a mouthful. So maybe what I'll start to do is to collate a couple of the questions for Professor Crea, who will be chairing the panel discussion to be discussing with our esteemed speakers. I would like to also introduce Professor Koji, who's also on the panel today with us. And so today on the panel, there'll be 5 of us, and we'll be talking through the issues and the questions that have been posed. So I think one of the most interesting questions that came up was the fact that we're dealing with an inflammation pathway. And someone commented that perhaps the rheumatoid arthritis patients may be at less risk of cardiovascular disease, mainly because they use agents like methotrexate, maybe even anakinra. Would the panel maybe like to comment on that? Professor Koenig or Professor Lorenzatti or Professor Crea? Thank you.
So the question is about methotrexate has been used in rheumatology with a very good result, and some meta-analysis and some small trial have shown good results, but the proof in the CIRT study was negative, and even more, methotrexate didn't alter or didn't reduce any inflammatory biomarker like C-reactive protein or interleukin-6, for example. I think as I have mentioned before, the only compounds that have shown good result was canakinumab and was also colchicine, but canakinumab is have shown more strong modification of biomarker of inflammation. I think the future probably may be the utilization of in this way. For example, ziltivekimab is a fully humanized antibody against the interleukin-6 ligand and produce a profound modification in C-reactive protein, for example, in terms of 80–90%. I think the future probably we will focus. In fact, there is a trial that named SEUS that I think is going to be running in few time, and I think that the future of this pathway will be the most useful in the prevention of cardiovascular disease.
Alberto, if I may just add to what you said with regard to CERT, I think there are 2 additional points. One, you mentioned already that there was no reduction in inflammatory markers, as we have seen in CANTOS, for example. So maybe that methotrexate mainly works through different mechanism. And the second point, I think, which is important to stress in contrast to CANTOS, the inflammatory burden measured by C-reactive protein was fairly low in CERT. So these are difficult to compare and may, at least in part, explain the failure of methotrexate in CERT.
Thank you both. Professor Crea?
First, thank you, Wolfgang and Alberto, for your wonderful lectures. And definitely, ischemic heart disease remains the #1 killer, and addressing the residual risk by anti-inflammatory treatment is an important goal. I am a bit concerned, anyway, about safety. This is something we shouldn't forget. For instance, with canakinumab, there was an excess of mortality for infection in patients randomized to canakinumab as compared to placebo. And regarding colchicine, we had recently published in the European Heart Journal an interesting meta-analysis showing an excess of non-cardiac mortality associated to colchicine. So I think that the safety issue is to be seriously considered. What are your feelings about this important topic? Alberto and Wolfgang.
Yeah, if I may start, I think you're perfectly right. Safety issues are of concern. And what you alluded to, I think, was specific data coming from LODOCO-2, which showed an increase in non-cardiovascular mortality, which I think until today is still unexplained. It's a whole variety of different causes, so you cannot allude it to just one specific cause. And I think there were other issues with the LODOCO-2. There was mainly an effect seen in Australia, but not in the Netherlands, which started later and maybe treated these patients more aggressively with traditional targets. So there's still some open questions, and safety obviously is of utmost importance, in particular since this drug will given long-term and not as during pericarditis or gout only for a very short period of time.
Thank you, Professor Lorenzatti.
Unmute, please. Unmute.
Yes. Professor Lorenzatti, we can't hear you. Professor Lorenzatti?
I agree. Yes. I agree with Professor Koenig and with Filippo. The safety issue are very important. And also in Koji, with the use of colchicine, I would like to add some concerns about renal function. In patients with some chronic kidney disease may be a problem, the utilization of colchicine. And also, I would like to reinforce the concept that there are some concern regarding a marginal but important increase, as Filippo said, in non-cardiovascular mortality with the chronic use of colchicine. This is an important point.
I wonder though, is it because of the doses that was used in the studies? Could they be used in lower doses? Would that make a difference?
Yes, that's right. Absolutely right. In the studies that the use of colchicine was based in a very, very low dose, I mean 0.5, this side effect of safety effect that are concerning us is less than with the use, for example, of 1 milligram in some studies.
And I think
yes.
in all the major studies that you have alluded to, Alberto, that the same dose, namely 0.5 milligrams per day, have been used. So it's fairly low, and then no difference among these large endpoint trials.
Well, you know, it's like antithrombotic treatment. They are very useful, but they increase the bleeding risk. We are between Scylla and Charybdis, and it is difficult to find the sweet spot. And with anti-inflammatory treatment, I think it's more or less the same thing, because inflammation can be dangerous, but it is also important in the work of our body because it's protective against infections. So I think that we have to go for the sweet spot, and the search probably will not be quick. But we had an important discussion today, Professor Hasegawa. Professor Hasegawa, do you have questions for our speakers?
Yes, just I'd like to make two comments. One comment is the difference between Kanto study and colchicine study. Kanto study targeted the patient with high level of CRP, but colchicine did not. So I think the inflammation is a big entity, and I think we need to more specifically identify what is the pathway that led to the cardiovascular event. And colchicine just generally inhibit inflammation. So I think we need to more specifically targeted some kind of inflammatory pathway, maybe that IL-1 beta or IL-6. So I think we need to more recognize what is the mechanism, why that colchicine reduce the cardiovascular event, but methotrexate did not reduce the cardiovascular event. Thank you very much.
If I may,
think that, yeah, please, Wolfgang, please go.
If I may add to that, I think with regard to mechanism, that's really interesting. And I think there's still some controversial issues. So for example, if you look into the fact that in Colcott, they were randomized within the first 30 days. And as you may remember, because it appeared in the European Heart Journal, there was an analysis that clearly showed the majority of the effect is seen in those where you initiate this therapy very early, namely in the first 3 days. And this is supported, for example, by data by imaging data that have been published a few years ago, showing that colchicine may be able to reduce infarct size. But on the other hand, you see the same magnitude of the effect in Lodoco and in Lodoco 2. And I mean, these patients, to my knowledge, were included, let's say, 1 to 2 years after an acute effect. So could maybe postulate that there are different mechanisms in these different studies that are effective.
So if I may sum up so far, it sounds like Professor Crea has also mentioned about the balancing on the tightrope where inflammation is concerned. We certainly need to address inflammation, but we don't have a very good way of addressing it, because when we try to treat it with canakinumab, for example, we increase the risk of infections. And then with colchicine, it seems like after the ACS situation, it didn't seem to help very much, although in some trials it did help some. So perhaps it's really about the dosage as well as perhaps we haven't quite found the right way to manage inflammation in these settings yet. I think there were some questions that the audience are asking, and everyone's very interested in statins, right? We thought statins could also reduce inflammation. So I think they were troubled to find out that even at very low LDLs, there's still residual risk. So some of the audience wants to know, what do we do for people like this? How do we recognize them? And when do we consider therapies on top of very low LDL or related statin treatments? And perhaps Professor Koenig, you could address the question, or Professor Crea?
I'm not sure if I got the question. Is that the question that shows up in the chat?
Yes, I was summarizing a couple of the similar ones. There were questions about how inflammation is addressed by statins. And so if we use statins and related LDL lowering treatments, and the LDL is already very, very low, there's still residual risk. When do we consider using alternative agents like canakinumab or colchicine on top of these people who are high risk?
Yeah, I mean, certainly you would only do that in patients who do have a proven residual risk. And I'd try to introduce a few examples showing that even at relatively low doses of, at low levels of LDL, that we can achieve these days with PCSK9 inhibitors or with compounds that block the synthesis of PCSK9 intracellular. There's still a modulation of the risk if you look into C-reactive protein across tertiles. So these would be the candidates, but I mean the application of drugs we have already discussed, and it's still the safety concern is still, I think, dominating. We definitely need more data on colchicine. Canakinumab is out. It will probably get its indications in the cancer field. There are a number of trials underway in that area, but not for cardiovascular. And then we will see what new drugs bring us. And I'm very eager to see the ZOIS trial, which is with ciltivekimab that Alberto has mentioned. There's a number of activities, and ultimately I'm quite confident that we will find our way through this jungle, I would say, of really redundant and complex mechanism. Alberto made a really strong point that inflammation is a complex and difficult target to address, and that will keep us, I guess, busy for quite some time.
Doreen, we have time for one more question.
Just a little bit of time, yes. Just okay. One question, very quick one.
I had a question which stems from your presentations. You said we have fissure and erosion. And indeed, 40% of patients with an acute syndrome present plaque fissure and 40% erosion. Now, my feeling is that an anti-inflammatory treatment works with fissure, but is unlikely to work with erosion, which is a totally different mechanism. Do you think that we should go more focused, more specifically in addressing fissure versus erosion? Unmute, please, both of you, Wolfgang and Alberto, unmute.
I think that was taken from obviously from your paper, and you're quite right. These are different pathophysiologies, but my point is what we have looked so far in terms of systemic inflammation is mainly focused on CRP. I mean, it's a terrific analyte. There's no question. But I would also assume that there is inflammation besides C-reactive protein, even if the C-reactive protein is not grossly elevated, there may be inflammation present. And we recently did a study looking into vulnerable plaques and identified by proteomic analysis a significant number of quite other molecules related to inflammation. And yeah, I think the research is at its beginning if it comes to inflammation and fissuring of plaque, but it's an interesting area and should be followed.
And I think just a few comments. In the near future, nowadays, there are many investigations using the combination of MRI and PET, and this is a very interesting way for identifying different types of inflammation in plaques. This is a new area that is growing in a very interesting way.
Thank you both. Thank you, Professor Crea. That was a very challenging question for the two of them. Maybe in the last 10 seconds, may I ask you a cheeky question? If you had money and you were to invest in a drug that's likely to reduce cardiovascular risk, which drug is this going to be? May I invite Professor Koji, please, to be the first person to say?
Okay, thank you very much. I think before addressing targeting the inflammation, I think lowering the LDL cholesterol level is much more important. Actually, when we look at the medical record, most of the patients LDL cholesterol level is above 80. So I think just lower the LDL cholesterol level first, lower than 50 milligram per deciliter. Then if the CRP level is too high, we should consider the target therapy targeting the inflammation. Thank you very much.
Okay, so Professor Koji is saying a statin then. Okay, how about Dr. Lorenzatti? Which drug will you invest in? Which medication are you going to invest in that is going to give you the bang for the buck?
This is a very interesting question. I have no the crystal ball, but I think regarding just pure anti-inflammatory pathway, I prefer to continue investigating the pathway of interleukin-6.
Oh, okay, very nice. So one of the monoclonal antibodies then, like anakinra, one of those agents. Yep. Okay. So Professor Lorenzatti has his vote on that. You're muted, Professor Lorenzatti. We can't hear you.
Maybe anakinra, maybe siltivekimab, etc. But I think this is a proper pathway in order to investigate more research.
Interesting. Thank you. Professor Crea, what's your money on?
Well, two things. First, I think it's important primordial prevention. And now we have polygenic risk scores which can identify high-risk patients since birth.
Absolutely.
In these patients, I would vaccinate these patients with inclisiran starting very early.
Nice.
When we come to inflammation, I think that we still have to identify the ideal target. For instance, a few years ago, we published a study showing that in acute coronary syndrome, there is a protective molecule, CD31, which is lost. And I think that perhaps this is the way to go. Rather than giving potent anti-inflammatory drugs, we can target molecules which are reduced, protective molecules which are reduced during the acute phase, and they can become an interesting therapeutic target.
Okay, so no real drug that's known to us yet. So you're investing in it, and maybe you become the next millionaire on that. What about you, Professor Koenig?
I would agree with Filippo. I mean, we are realizing more and more that prevention is that we have neglected it for quite some time. It's more important, and obviously the inclisiran would offer a tremendous possibility for primary prevention, provided that we can overcome economic hurdles, which certainly is really an issue in primary prevention. Anti-inflammatory drugs, I think what I've seen so far published in terms of biomarkers, the clinical trial is underway. Siltevecumab looks quite interesting, so maybe we will get a drug, in particular in patients with high risk with CKD. I think it's a CKD group that's being invested, post myocardial infarction. But that would be an option for those who have disease already. But certainly, I would favor a primordial or primary preventive approach. That would be the future perspective in my mind.
Thank you so much for sharing your pulse, gentlemen. We were very privileged to have you here this afternoon, and thank you for sharing your concepts with us. Because I used to question my physiology teachers when they taught me all these inflammation pathways. I'm like, why am I studying this? But this all makes so much sense. So we thank you for your time. We thank you for joining us, and we'd like the audience to also remember to come back in about 2 minutes' time for our opening plenary on COVID-19. So we'll see you again. And this is ISCP checking out. Thank you so much for joining us.
Bye-bye. Thank you for
Thank you all.